Hola a todos, buenas noches. Muchas gracias por conectarse hoy día con nosotros. Tenemos una nueva sesión de nuestras reuniones mensuales de la Asociación Chilena de Patología. Hoy día tenemos invitados y moderadores de lujo, así que hoy día nos acompaña la doctora Violeta Riva, del Hospital Guillermo Gran Benavente, de la Universidad de Concepción, y el doctor Álvaro Ursúa, del Hospital Clínico de la Universidad de Chile, quienes estarán moderando y a quienes doy la palabra para que nos presenten a nuestro invitado de hoy. Agradecer a la Asociación Chilena de Patología, a la Sociedad Chilena de Gastroenterología y a Eurofarma que está auspiciando la reunión de hoy. Muchas gracias a todos y buenas noches.
Gracias, doctor Araf. Buenas tardes a todos. En esta oportunidad tendremos un gran invitado que presentaré a continuación. Y con el doctor Álvaro Ursúa moderaremos este meeting y la hoja de ruta será la siguiente. Primero escucharemos la charla de nuestro invitado internacional. Luego Álvaro presentará 2 casos clínicos cortos que comentaremos con el panel. Y posteriormente se resolverán las preguntas y las dudas de la audiencia. Recuerden que todas las preguntas por Zoom las pueden realizar a través de las 2 plataformas en Zoom durante el transcurso de la reunión en la casilla de preguntas y respuestas que está acá abajo en los que están conectados en Zoom y vía YouTube en el cuadro superior a la izquierda en el cuadro de chat. Recuerden también que la plataforma Zoom, esta charla tendrá traducción simultánea si ustedes ponen en español o en inglés según lo que ustedes necesiten. Y actualmente tenemos varios conectados, tenemos una gran audiencia y bueno, ahora voy a presentar a nuestro invitado de hoy. Esta tarde tenemos el placer de contar con un gran invitado internacional. Dr. Manjalisi es profesor asistente de medicina y hepatólogo de trasplantes del Centro Médico de la Universidad de Vanderbilt en Nashville, Tennessee, Estados Unidos. Su investigación a lo largo de los años se ha enfocado en cardiomiopatía cirrótica y las complicaciones pre- y post-trasplante de esta entidad. Y además, él es uno de los miembros fundadores del consorcio de la cardiomiopatía cirrótica que publicó los criterios diagnósticos de esta entidad en el año 2020 en el Hepatology. Hoy nos presentará la conferencia Cardiomiopatía cirrótica, cómo la identifico y cuál es su relevancia clínica. So, welcome, Dr. Isi. Good evening. We are very happy that you join us in this meeting. And when you're ready, you can start your lecture.
Thank you so much, Dr. Rivas, for the introduction. Good evening, everyone. I would like to thank the organizers for having me here at the Chilean Association of Hepatology event. Muchas gracias, and it's a pleasure and honor to be here. So today I'll be talking about cirrhotic cardiomyopathy, how to identify it, and what's its clinical significance. I have no financial disclosure. Here's the outline of our talk. So we'll be talking about definition and pathophysiology of cirrhotic cardiomyopathy first. Then we'll touch on the diagnostic criteria, the prevalence, and we'll conclude by talking about the clinical significance of cirrhotic cardiomyopathy in patients with cirrhosis and liver transplant candidates and liver transplant recipients. Cirrhotic cardiomyopathy is defined as cardiac muscle dysfunction in patients with cirrhosis who do not have known cardiac pathologies. Its pathophysiology is a little puzzling. It involves multiple factors that occur in the setting of hyperdynamic circulation that our cirrhotic patients live with. And most of these factors were understood based on animal studies. So first, there's myocardial and vascular inflammation. Second, subendocardial edema. Third, myocardial hypertrophy. And fourth, myocardial fibrosis. If you look at these factors, subendocardial edema is not surprising in our patient population when there is volume overload. Myocardial hypertrophy is not very surprising either, because there is a phenomenon in which when there is salt or sodium overload in the body, there could be myocardial hypertrophy, and that's been described a long time ago. But what's more puzzling is the myocardial and vascular inflammation as well as the myocardial fibrosis. Recently, this wonderful study from the NIH that was published last year showed in the mouse model that when you induce a phenomenon that resembles cirrhosis through bile duct ligation, that leads to massive hepatic inflammation and fibrosis. Within 2 weeks, they noticed on the animal that there are several cardiac changes, such as systolic dysfunction, diastolic dysfunction, surprisingly myocardial and vascular inflammation, as well as myocardial oxidative stress. On the human side, we recently learned that these observations can be made using MRI, cardiac MRI. So there's this study from October last year that was published in Radiology that showed that using cardiac MRI to look at late gadolinium enhancement, which is a surrogate for cirrhosis, T1 relaxation time, and T2 relaxation time, which is a surrogate for myocardial inflammation, as well as extracellular volume fraction, which can reflect fibrosis and or edema. When they looked at these variables and compared cirrhotics or patients with cirrhosis compared to patients to healthy controls, they realized that cirrhosis leads to increased representation of these markers in patients who are affected by it. So the conclusion was that patients with cirrhosis tend to have more myocardial fibrosis, more myocardial inflammation, and more myocardial edema, which reflect or mirror the observations that were made in the animal model. Now, based on these observations, it's conceivable that cirrhosis leads to myocardial inflammation and oxidative stress, which in turn leads to myocardial fibrosis, because as you know, in any organ, when there is prolonged inflammation, it eventually leads to fibrosis. And we're well familiar with that in the liver, for example. And then the myocardial fibrosis leads to remodeling and cardiac dysfunction. And when it comes to remodeling, we have to remember that heart failure, in order for it to develop, it goes through 4 stages. Stage A, having risk factors for it. Stage B, have remodeling or structural changes, which is what cirrhotic cardiomyopathy is. Stage C, developing the clinical symptoms, and D, developing refractory symptoms. So stage B is more of a echocardiographic findings, which is what cirrhotic cardiomyopathy before the clinical presentation is. So the first attempt to define or to make diagnostic criteria for cirrhotic cardiomyopathy was made in 2005 during the World Congress of Gastroenterology in Canada. And at that time, systolic dysfunction was defined as left ventricular ejection fraction less than 55% or blunted response to stress, while diastolic dysfunction was defined peak velocity flow in early diastole to late diastole, E to A ratio of less than 1, isovolumetric relaxation time of more than 80 milliseconds, or deceleration time more than 200 milliseconds. So this was a great attempt to establish diagnostic criteria for this disease. But these criteria came with limitations, which we learned of more later on. So for ejection fraction, which we always think of, or it's almost the only thing that we think of when we consider patients for transplant or TIPS, in addition to right ventricular systolic pressure, we think of that as well. But ejection fraction gets our attention more than any other echocardiographic marker. But we have to remember that ejection fraction, when it comes to its measurement, there is significant inter and intra-observer variability, up to 10%. So a patient who's going to transplant with ejection fraction of 52%, it could very well be 42%. Additionally, our patients have systemic vasodilation, which leads to decreased afterload. And therefore, there's inflated ejection fraction, that inflated value for ejection fraction, because there's the systemic vascular resistance is low, there's vasodilation, so the heart doesn't face that much resistance. So the ejection fraction is value is inflated. So putting these together, we realize that it's not the most optimal marker. The other marker that was determined by the 2005 criteria was blunted response to stress. And that's often confounded in our patient population by non-selective beta blockers. And there's no actual definition that is agreed upon universally for blunted response to stress. So the limitations about ejection fraction make us wonder, should we consider 60 as the cutoff, not 50%? So this study that was published in Hepatology last year showed that in patients with ejection fraction less than 60% and MELD of more than 20, there is increased 90-day mortality compared to patients with ejection fraction of more than 60% and MELD more than 20. And that becomes more pronounced as the MELD gets to more than 35. The study also showed that if we look at the long-term mortality, close to 5 years, the cutoff of 60% does still have increased risk for mortality as opposed to less than 60%. So maybe we should consider a higher cutoff, but this is only one study, but it opens the door for more investigations in that direction. With regard to the diastolic dysfunction criteria from 2005, they also come with limitations. So the E and E to A ratio of less than 1, it's preload dependent. So there are studies that shows, or there's a study that shows if you do paracentesis for the patient, the EA ratio could be different pre and post paracentesis. And it's also confounded by age and others. And if we look at this figure, I mean, none of us is cardiologists, but you see that you can tell that EA ratio in the diastolic dysfunction grade 2 is similar to that in patient with normal diastolic function. So you see, like in normal and grade 2, it looks similar. So sometimes it's confusing to interpret it because it can look like normal, but the patient doesn't have normal diastolic dysfunction. IVRT, it exhibits a U-shaped phenomenon, so it shortens as the diastolic dysfunction advances, so you can't rely on it either. So because of these limitations, the Cirrhotic Cardiomyopathy Consortium, which consists of specialists in cardiology, hepatology, and anesthesia, decided to revise the 2005 criteria in view of the advancements made in echocardiography over the prior 15 years. So the new criteria suggest considering ejection fraction of 50% or less, or global longitudinal stress of less than 18 as a surrogate for systolic dysfunction. Sorry, my apologies. And for diastolic dysfunction, you need multiple variables to make the diagnosis. So you need average EE ratio of more than 14, tricuspid regurg velocity of more than 2.8, septal E prime less than 7, or left atrial volume index of more than 34. Patients who have 3 or more of these variables, they have diastolic dysfunction that can be graded, and we'll talk about the grading in a second. Patients who have only 2 of these variables, they have diastolic dysfunction, but the grade is indeterminate. Therefore, we need to do additional testing to determine the grade for those patients. I'm going to spend a couple of minutes here talking about global longitudinal stress because, as I said, most of our attention goes to ejection fraction when we talk about echoes, and some of our cardiology colleagues would say ejection fraction is the Achilles heel of cardiology. So for global longitudinal stress, it is basically, global longitudinal strain, it is basically the percent of myocardial fiber shortening during systole. So the change in fiber when it shortens during systole relative to its relaxation length, diastole length. So since we're talking about shortening, it is a negative value. So you see here in the figure, and I don't think the video would work here because we just switched computers before starting the presentation, but so the video is not working here, but the yellow lines, the yellow dots would get closer to each other during systole, which means the fibers are getting shorter. When we think of this shortening of this negative value, it could be confusing because, you know, when we say the change in strain was from minus 18 to minus 16, you would think that minus 18 is worse, but it's actually better. So to minimize this confusion, the guidelines suggest thinking of or considering strain as an absolute value. So think of it as the absolute value is 18 or more. So when you see the minus before the number in the echo reports, disregard that when you're analyzing the change or analyzing for cirrhotic cardiomyopathy or any other myopathic phenomenon. So think of it as an absolute number. So strain, so this picture, which is what they call in echocardiography world, bullseye. So there are multiple segments for the heart here, and there is these minus values are the strain or the muscle strain for each segment. But then the software will give you the final global longitudinal strain for that reflects the status of these segments cumulatively. The strain has been shown in multiple studies to predict cardiac events better than EF. In fact, the impairment in strain can precede that of EF. And it also has better reproducibility, so less operator dependent or less inter and intra-operator variability than ejection fraction. Now, with regard to the diastolic dysfunction, as we said, for patients who have two criteria only, they have diastolic dysfunction of indeterminate grade. So we need to obtain more variables, such as EA during Valsalva or left atrial strain. For patients who have three variables that are normal, they have normal filling pressures. If they have only one normal value, that they do have diastolic dysfunction, because that means the other three values are abnormal. What about QTc prolongation? So as you know, most of the studies that tried to investigate cirrhotic cardiomyopathy in the past focused on QTc prolongation because everybody gets an EKG before transplant and several of them after transplant with every admission. So it's easy to assess. And at the same time, QTc prolongation was observed in patients with cirrhosis, so it was thought to be reflective of cirrhotic cardiomyopathy. When the Cirrhotic Cardiomyopathy Consortium revised the criteria, we decided to eliminate QTc as a supportive criterion, because our thought process is, if this is a myopathic phenomenon, we need imaging to figure it out. So we need echocardiography to figure it out, or MRI to figure it out. So EKG alone cannot be the diagnostic tool. And not surprisingly, a study came out recently in the American Journal of Transplantation that shows the QTc prolongation does not correlate with the echocardiographic changes, whether you want to use the Cirrhotic Cardiomyopathy Consortium criteria from 2020, or if you want to use the World Congress of Gastroenterology criteria of 2005. Whichever set of criteria you decide to use, QTc does not correlate with it. The same group from Australia did another study that showed that QTc does not predict post-transplant mortality, whether early or late. So that validates our point that QTc should not be considered in the diagnostic algorithm for cirrhotic cardiomyopathy. So now we have these criteria that we talked about. So we have two systolic criteria, which are ejection fraction and global longitudinal strain, and four diastolic criteria. For systolic, we need one of the two. For the diastolic, we need three to grade the diastolic dysfunction, or we need two to make a diagnosis of diastolic dysfunction that's indeterminate in terms of grade. So how prevalent is cirrhotic cardiomyopathy? Why do we need to care about it? So there are three studies that were published this year that apply the new criteria to to transplant candidates. So our study was in 141 patients. I actually was part of it when I was in my prior institution during training at Mayo Clinic. So we had 141 liver transplant candidates that we evaluated for cirrhotic cardiomyopathy retrospectively. So in our criteria, in our study, the prevalence was 34.7%. Most of that prevalence was driven by diastolic dysfunction. In the other two criteria from our European colleagues, it showed that the prevalence is about 28%, and it was largely driven, or it was more driven by systolic dysfunction than our own study. So in general, if you were to think about this, I would say roughly 30% of our transplant candidates have cirrhotic cardiomyopathy. So what's the significance of cirrhotic cardiomyopathy? So let's talk first about its significance in patients with cirrhosis. And in my mind, when we talk about this, there are three main categories of clinical significance that we need to address in the setting of TIPS, in the setting of beta blockers, and the setting of weightless mortality. So let's talk about TIPS first. So what happened in TIPS, as you know, once we create the shunt, we increase the preload to the heart. Once that happens, there's worsening of the hyperdynamic state that already exists in our patient population. So if we think about this increased preload or increased burden of the heart from number standpoint, here are the numbers. So the cardiac output would go by 32 to 34%, cardiac index by 26%, right atrial pressure, left ventricular ejection fraction, and end diastolic volume, they all go up. So there's increased burden on the heart. And if you combine the increased burden from TIPS with cirrhotic cardiomyopathy, conceivably, these patients will have cardiac decompensation and or death as a concept. But this concept was shown in two recent studies. The first one was a retrospective study for 114 patients who had impaired, some of whom had impaired strain to a value of less than 16.6%, and those had increased risk for 2-year mortality after TIPS. The other study was prospective, and it showed that abnormality or increase in E prime or left atrial volume index as surrogates of diastolic dysfunction, that was associated with increased in 1-year cardiac decompensation. How common is cardiac decompensation? So there are different studies that assessed it, and it really depends on the observation period studied or observed. So within 1 week, it was reported to be 1% after TIPS. Within 3 weeks, it was about 13%. In 1 year, it was about 20%. Each of these values within that time frame is significant. So we really need to do more to prevent or minimize the possibility of cardiac decompensation post-TIPS. Now, with regard to beta blockers, our knowledge about beta blockers' interaction with cirrhotic cardiomyopathy recently started evolving. So there were 2 studies in Journal of Hepatology that addressed this topic. So the first one was by our colleagues from Barcelona Clinic, and in that study, they had 403 patients, 190 of whom were decompensated. So what they did when they enrolled the patients in the study, they measured their hemodynamic pressures and cardiac surrogates, such as cardiac output, at the time of starting beta blockers, then 1 to 3 months later. So they realized that patients whose cardiac output, decompensated patients, whose cardiac output dropped below 5 liter per minute was I'm sorry, my kid is here. I'm so sorry, 1 second. Zena. I'm so sorry. So patients who had a drop in cardiac output to less than 5 liter per minute had increased risk of death. And those patients were noted to have reduced or impaired global left ventricular strain to minus 18 or 18, think of it as an absolute value, as opposed to 21. So the authors were they brought up the possibility that this could be related to latent or cirrhotic cardiomyopathy. The other study, it actually assessed the impact of cardiac function, refractory ascites, and beta blockers on these patients. And it showed that while refractory ascites had an impact on waitlist mortality, as you can see here. Beta blockers alone did not have an impact on waitlist mortality. However, if we combine the impact of beta blocker, or we analyze the interaction between the impact of beta blockers with the impact of reduced left ventricular stroke work index, which is a surrogate of cardiac function, we see that the interaction of beta blockers with left ventricular stroke work index have a detrimental impact on waitlist mortality. This study was prospective in terms of data collection, but retrospective in terms of the analysis. 50% of the patients were on beta blockers, 33% had refractory ascites. But the point here is that in this study, beta blockers alone in these patients did not confer an increased risk of death, only when they were combined with impaired cardiac function. And the authors recommended careful cardiac evaluation before starting patients on beta blockers. But I have to say, neither of these studies assessed the patients based on the Sorotic cardiomyopathy criteria. So we don't know if we assess Sorotic cardiomyopathy based on the new criteria in relation to non-selective beta blockers, will we have the same results about the interaction of the two. The last part of the clinical significance in patients with cirrhosis that we will talk about is waitlist mortality. So this study that used MRI to assess the myocardial extracellular volume as a surrogate of Sorotic cardiomyopathy showed that patients with increased extracellular volume, who are more likely to have myocardial fibrosis, and which is reflective of Sorotic cardiomyopathy, they have worse transplant-free survival. Now let's shift gears to the clinical significance in liver transplant recipients. So first, let's talk about cardiovascular morbidity and mortality. Then we'll talk about reversibility. So with regard to the morbidity, cardiovascular comorbidity. So our study that I mentioned, it was retrospective to a single center. We had 141 patients with hepatic decompensation. We had two blinded cardiologists, echocardiographers review the images, and the mean follow-up time was 4.5 years, during which we noticed that patients with Cirrhotic cardiomyopathy had an increased risk for post-transplant cardiovascular disease, more than twofold, as you can see here. And the Cirrhotic cardiomyopathy was prevalent in about 47% in patients with NASH, 32.7% in alcohol, and 20.4% in other etiologies. And this is important because in large population studies, in the general population, diastolic dysfunction, for example, was prevalent in 1%. So even if we assume that patients with NASH or ALD, they have other factors to have diastolic or systolic function, but the group of the non-NASH, non-ALD had 20.4%. That's remarkable compared to general population, which has only 1%, which speaks of the magnitude or the effect of the Cirrhotic cardiomyopathy in these patients. In our study, with regard to new development of cardiovascular disease post-transplant, 13 had coronary artery disease, 14 had CHF, and 12 with arrhythmia, and 5 patients with stroke. Cumulatively, 27 patients had new cardiovascular disease post-transplant. The impact of Cirrhotic cardiomyopathy on outcomes was observed more for late outcomes. So in the first 90 days, there was no association observed, but was observed for the late outcomes. And again, it showed an associate or an increased risk for by more than twofold. And I have to say there is no impact of Cirrhotic cardiomyopathy on mortality in our study. Now, how about heart failure? Because at the end of the day, this is Cirrhotic. This is a cardiomyopathic phenomenon. So we always wonder about its impact on heart failure. So there was a trend, but it's not statistically significant. The p-value is 0.08 for association between Cirrhotic cardiomyopathy and post-transplant heart failure beyond 90 days post-transplant. And heart failure is very important to focus our efforts on because recent study, which was based on an inpatient nationwide sample, showed that between 2002 and 2011, so almost 10 years, there is an increased incidence of heart failure in liver transplant recipients, and there is increased incidence of dysrhythmia too, both of which can conceivably be attributed to cirrhotic cardiomyopathy. And the CHF admissions increase, and overall we have to mention that 20% of the hospitalizations after transplant were due to cardiovascular disease. And the decline that you can see here in stroke and coronary artery disease can be explained by perhaps we are getting more aggressive with statins and aspirins in our patients post-transplant, but we need to do more for heart failure and arrhythmia, and hence the uptrend. Back to our study, so when we analyzed the individual variables, so for example, strain alone, we realized that strain in the 119 patients that we analyzed, that we had access to strain in them, an absolute value of less than 20.6 was associated with increased risk of heart failure. An absolute value of 20.5 was increased with increased risk of coronary artery disease. With regard to the diastolic variables, an EE prime ratio of more than 9.2 was associated with increased risk for cardiac events overall and specifically atrial arrhythmias. And left atrial volume index was associated with increased risk for first-year mortality and CHF. And this is not surprising because in the general population, there are comparable results. But it's nice to see the importance of these markers validated in patients with end-stage liver disease, and after that, during their liver transplant life. And there was a prior study that showed relatively comparable data to ours in patients and post-transplant patients, and showed that increased LAVI and increased EE prime are associated with increased heart failure in the short term post-transplant, and its increased LAVI or left atrial volume index is associated with increased risk for increased risk for impaired 1 year and 5 years survival. So our studies support these findings, and this is in post-transplant patients, and support a large body of evidence in the general population. Now last, let's talk about reversibility. So there was this study that was published in the Journal of Cardiovascular Magnetic Resonance in 2020, and it showed that extracellular volume, which as I said could be surrogate for cirrhotic cardiomyopathy as it can reflect myocardial fibrosis and edema, it goes down within 1 year after transplant. And the global longitudinal strain, it goes down after transplant. And the authors were suggesting that cirrhotic cardiomyopathy may reverse post-transplant, but we have to realize that both of these values of global longitudinal strain, these are normal values. So 24.9 is normal and 20.6 is normal too. And the decrease in extracellular volume, while it did happen, but does it reflect change in cardiac function? And does it reflect that patients with cirrhotic cardiomyopathy got rid of it a year after? So when we look more into the data, we realize that this study had only 1 patient with cirrhotic cardiomyopathy. So only 1 patient with diastolic dysfunction and no patient with systolic dysfunction. So we cannot make conclusions about the reversibility of cirrhotic cardiomyopathy when only 1 patient with cirrhotic cardiomyopathy was included. And 6 patients had T2 analysis, which is the analysis that's indicative of inflammation, as we discussed earlier. And only 1 patient had late gadolinium enhancement, which can reflect fibrosis. So while this study was great as showing the evolution of changes in extracellular volume in the heart after transplant, we cannot make conclusions about reversibility of cirrhotic cardiomyopathy. In fact, in our study, we had echoes on 22 of the 47 patients who had diastolic dysfunction or cirrhotic cardiomyopathy. We had it post-transplant because of a clinical indication, and we noticed that only 6 patients had a resolution of diastolic dysfunction within a year, and 16 patients did not have that. So again, these are small numbers, but we don't have evidence at this point to say that cirrhotic cardiomyopathy can reverse. In fact, the post-transplant outcomes that we observed in our study, from heart failure to arrhythmia, they serve to suggest that cirrhotic cardiomyopathy does not seem to reverse, or at least some component of it does not seem to reverse. And therefore, our Cirrhotic Cardiomyopathy Consortium recommend that echocardiography should be repeated in patients with cirrhotic cardiomyopathy every 6 months until 2 years after transplant to monitor for interval changes in the cardiac function. Some experts from our cardiology colleagues would suggest to keep monitoring every 6 months until diastolic dysfunction or systolic dysfunction resolves. And some experts suggest that we should do the same for patients after TIPS. So despite all these recent studies over the past year or year and a half about cirrhotic cardiomyopathy, we still need to know a lot more about it. So as you know, cirrhotic cardiomyopathy throughout these years has been considered as a contributing pathology for hepatorenal syndrome because of its impact on cardiac output. But according to the new criteria, does it still increase the risk of hepatorenal syndrome? The same for TIPS. What are the predictors of its worsening after TIPS? Does it affect survival after TIPS? What can cause reversal after transplant? What can predict reversal? What can we do to enhance reversal? So there's a lot of questions, and even in the pre-transplant sphere, or when patients have cirrhosis and they still they haven't gotten transplant yet, there are multiple questions about the association between severity of severity of their liver disease and severity of cirrhotic cardiomyopathy, and severity and the etiology of liver disease and their cirrhotic cardiomyopathy. So we have way more questions to answer, but that's great for this field because there's a lot of room for investigation or research in the sphere of cirrhotic cardiomyopathy. Now, in conclusion, the new cirrhotic cardiomyopathy criteria should be incorporated in the echocardiographic assessment in patients undergoing TIPS or liver transplant, given potential consequences. Cirrhotic cardiomyopathy may not be reversible, and it appears to confer an increased risk for post-transplant cardiovascular disease, and surveillance of cirrhotic cardiomyopathy may be of benefit. I thank you for your attention and hope to see you in Nashville. On the right is Nashville, on the left is our university campus. Thank you very much.
Muchas gracias, Dr. Easy, por su excelente presentación. Es un tema muy interesante y del cual, como usted expuso, se sabe cada vez más, pero todavía tenemos mucho por investigar y por aprender. Entonces es un tema realmente muy apasionante y es un estímulo para los que nos dedicamos al trasplante hepático para mejorar la evaluación de nuestros pacientes, tanto pre como post-trasplante. Como comentaba la doctora Rivas al inicio de la sesión, antes al iniciar la sesión, antes de las preguntas vamos a compartir un par de casos clínicos típicos que nos toca ver a los hepatólogos y nos gustaría escuchar la opinión del doctor Easy con respecto a estos casos. Voy a compartir mi pantalla ahora. Entonces, se trata del caso de una mujer de 58 años, ya que tiene como historia una cirrosis por enfermedad hepática grasa, ya por hígado graso. Ella es Child 6, tiene un MEL sodio de 16, está en lista de trasplante y tiene como complicaciones de la hipertensión portal, ascitis en tratamiento y encefalopatía, y además tiene un hepatocarcinoma de menos de 2 centímetros. Esta paciente además tiene otras comorbilidades, es hipertensa y tiene una enfermedad renal crónica con una creatinina que habitualmente está en 1.5. Es usuaria de furosemida, lactulosa, rifaximina, calcio y domperidona.
Disculpa, Álvaro, que te interrumpa,
¿sí?
pero aparece una advertencia en la imagen, entonces no se ve toda la presentación.
Perdón.
¿Podrías cargarla de nuevo, por favor?
Por supuesto. Voy a dejar de compartir. Voy a compartir nuevamente. A ver si comparto toda la... ¿Ahora sí?
Ahí está perfecto.
Ya, disculpen por el problema. Entonces, esta es una paciente que es una historia que estamos viviendo ahora, una paciente hospitalizada actualmente. Ella consultó por 3 días de bradipsiquia, fiebre y aumento del perímetro abdominal. Al examen físico estaba mínimamente con encefalopatía, ya tenía un examen cardiopulmonar sin alteraciones, ya una citis que había aumentado a grado 3 y edema de extremidades inferiores. Ya mostramos aquí algunos de los exámenes de laboratorio más importantes, una hemoglobina de 8.5, 79.000 plaquetas, su creatinina había subido sobre el basal de 1.5 a 1.8, y además también tenía elevación del nitrógeno ureico, una bilirrubina total de 2.7 y un INR de 1.6, y después de un par de días de hospitalización aparecieron cultivos positivos para un Streptococcus salivarius, que es un estreptococo de la familia Viridians. Esto motivó que se realizara un ecocardiograma que mostró un ventrículo izquierdo de tamaño normal, con una función sistólica normal, y una fracción de eyección del 65%. Tenía una aurícula izquierda severamente dilatada con un volumen indexado de 70.9, una disfunción diastólica grado 1 según la describía el ecocardiografista, ya con una E' septal de 6 centímetros por segundo y una lateral de 8, con una razón entre la onda E y la onda A de 0.8 y con una razón entre la onda E y la E' de 12.4. Tenía una velocidad de regurgitación tricuspida de 2.2 centímetros por segundo y se describían cavidades derechas normales con una presión sistólica de arteria pulmonar estimada de 25 milímetros de mercurio. Teníamos para comparar un ecocardiograma realizado 2 meses previo como parte de su evaluación de trasplante, ya en que se veía que la función sistólica también estaba mantenida, pero la fracción de eyección era del 56%, diferencia 65% en la previa. Tiene la aurícula dilatada también de un volumen indexado de 63 ml por metro cuadrado. No teníamos en ese ecocardiograma la velocidad de regurgitación tricuspidia, pero sí teníamos una razón entre la onda E y la onda E' de 12. Y también se describían las cavidades derechas como normales. La paciente recibió como tratamiento de su infección ceftriaxona, se suspendieron los diuréticos por la disfunción renal y se le agregó albúmina para manejo de la falla renal. Después de 2 días en la unidad de cuidados intensivos fue transferida a la sala general, y en la sala general tuvo aumento de la ascitis y aumento del edema, desarrolló taquipnea y aumento de requerimientos de oxígeno, y al examen físico habían crépitos pulmonares. Se realizó un TAC de tórax que mostraba congestión pulmonar, por supuesto por la contingencia se descartó una infección por SARS-CoV-2, y se realizaron exámenes en los que destaca un NT-proBNP de 28.900, ya en nuestro laboratorio menos de 300 negativo y más de 900 para la edad de la paciente es positivo probable, ya, y una troponina de 30.19 con un valor normal de menos de 11. Se transfirió nuevamente la paciente a la unidad de cuidados intensivos, se conectó a ventilación no invasiva, se le aplicaron diuréticos y tuvo una buena respuesta. Entonces la pregunta para el doctor Easy es si esta paciente tiene o no tiene una miocardiopatía cirrótica, dada la evolución que tiene, el ecocardiograma que tenía y lo que ocurrió, digamos, durante su hospitalización. Doctor Easy.
Thank you very much. Thanks a lot. This is a great case. So, she has mild diastolic dysfunction. So the question would be, is this from cirrhotic cardiomyopathy, or this is from other cardiac pathologies, especially that the patient has NASH? I think with this specific case, given the age, the diagnosis of NASH, probably obesity, and I think the patient had hypertension originally, correct?
Sí.
Yeah. So given all of that, I mean, she's at high risk of coronary artery disease, and the fact that her troponin, the highly sensitive troponin leaked to up to 30 from an upper normal limit of 11, that would push me toward doing a right heart cath or coronary CT in her to make sure that this is what we are seeing here. The cardiac dysfunction that we're seeing here is not reflective of ischemic heart disease rather than cirrhotic cardiomyopathy. Because at the end of the day, cirrhotic cardiomyopathy is more of a diagnosis of exclusion. In other words, like you see cardiac dysfunction, but you can't blame it on the cirrhosis until we rule out other causes. And in her case, with the troponin leak, I think we need to kind of like get an angiographic assessment of her coronaries and go from there.
Muchas gracias por la evaluación, doctor Easy, y muy importante me parece el último punto que tocó acerca del diagnóstico de exclusión, o sea, que la miocardiopatía del cirrótico es un diagnóstico de exclusión y muchos de nuestros pacientes tienen, digamos, también otras comorbilidades. Para seguir avanzando y mostrar el otro caso clínico, después podemos ver las preguntas de la audiencia y las preguntas que también tenemos nosotros, por supuesto. Voy a compartir nuevamente la pantalla. Y, perdón. Este es otro caso. Es un paciente de 30 años con antecedentes de una atresia de la vía biliar. Fue sometido a una cirugía de Kasai durante su periodo neonatal y desarrolló, como ocurre con muchos de estos pacientes, cirrosis posteriormente en la vida adulta, ya con complicación principal de colangitis recurrente y encefalopatía. Él se inscribió a la lista de trasplante recibiendo puntos de excepción por la colangitis y además presentaba cuadros de pseudoobstrucción intestinal recurrente que tiene que ver con su cirugía. Como otras comorbilidades, el paciente presenta sobrepeso. Era usuario de espironolactona, rifaximina, propranolol, ciprofloxacino, domperidona, pregabalina y venlafaxina. Y este paciente fue trasplantado el 11 de enero, ¿ya? Y como elemento a destacar, al quinto día post-trasplante desarrolla una hipertensión muy importante que requirió de infusión continua con labetalol por más de 72 horas, y esto se acompañó de aumento de requerimientos de oxígeno, y él tuvo una buena respuesta a los diuréticos. Lamentablemente este paciente tuvo una disfunción del injerto, desarrolló una colangitis isquémica y requirió de un retrasplante. Y después de su segundo trasplante, que fue el 3 de febrero del mismo año, ya al séptimo día post-trasplante presentó un cuadro de dolor abdominal en el cuadrante superior derecho, con taquicardia, hipertensión y disnea. Y en ese momento se realizó una tomografía computada de tórax, abdomen y pelvis que mostró congestión pulmonar leve y también una colección de fluido perihepática con aumento de parámetros inflamatorios, pero también con aumento de troponina y de dímero D. A este paciente no se le realizó ProBNP y tuvo una buena respuesta nuevamente al uso de antihipertensivos y al uso de diuréticos, y con respecto a la complicación de la colección no requirió de punción y esto regresó de manera espontánea finalmente con tratamiento antibiótico. En este paciente teníamos un ecocardiograma previo al trasplante, donde había una función sistólica descrita como normal, con una fracción de eyección del 65%. Tenía una dilatación leve de la aurícula izquierda, con un volumen indexado de 39.4, una velocidad de regurgitación tricuspida de 2.3, y tenía una E' de 7.8 septal y 13.2 lateral, con una razón entre la onda A y la onda E y la onda A, perdón, de 1.3, y una razón entre la onda E y la onda E' promedio de 10.4. Él tenía un ventrículo derecho normal, ya con una leve dilatación de la aurícula derecha y una presión sistólica de arteria pulmonar estimada como normal de 24 milímetros de mercurio. Entonces, acá la pregunta para el doctor Isi es que vemos que este paciente desarrolla hipertensión arterial después de ambos trasplantes, ¿ya? Sin una insuficiencia cardíaca evidente, digamos, una clínica tan evidente de insuficiencia cardíaca, pero sí con buena respuesta a los antihipertensivos y a los diuréticos. Entonces, podríamos decir que este paciente tiene una miocardiopatía cirrótica, una cardiomiopatía cirrótica, o simplemente es un paciente que post-trasplante desarrolló hipertensión de otra causa. ¿Cuál es la opinión del doctor Isi?
I think the latter, because I think he doesn't meet the criteria for cirrhotic cardiomyopathy, and I think the pulmonary congestion that was noted may not be related to cirrhotic cardiomyopathy.
Muchas gracias, doctor Isi. Es una situación clínica que nos toca ver frecuentemente en los pacientes trasplantados y creo que es muy importante, gracias a lo que nos ha enseñado, aprender a reconocer realmente cuándo realmente una miocardiopatía del cirrótico y cuándo no. Ahora la doctora Rivas nos va a compartir algunas preguntas de la audiencia. Sí. Doctora.
Gracias, Álvaro, por los casos clínicos, y gracias, doctor Isi, por su excelente conferencia. La verdad, este es un tópico, un tema que los hepatólogos creo que estamos subdiagnosticando, y es bueno ponerlo en tapete hoy en día, y sobre todo también en los pacientes post-trasplante, como dijo Álvaro en su último caso clínico. Me parece una relevancia clínica muy importante, y muchas gracias por su presentación y por la linda y tierna interrupción que tuvimos. Todavía no hay preguntas de la audiencia, pero yo tengo dos preguntas que yo creo que nos van a ayudar en la práctica clínica habitual a nosotros como hepatólogos y gastroenterólogos. Doctor Isi, ¿qué debiéramos solicitar en una ecocardiografía en forma específica, o en qué parámetros debiéramos fijarnos o conversar con el cardiólogo, el ecocardiografista, enfocarnos en particular? ¿Podría hacernos un resumen o checklist para la práctica clínica habitual?
That's an excellent question. So, this question highlights the importance of closely collaborating with our cardiology colleagues, especially in the care of our transplant candidates or patients going through TIPS or needing echo for other reasons. So, what we have tried to do in our institution, and I know that other institutions have started to do that, we're communicating with our cardiology colleagues the variables that we want them definitely to be included in the report, such as global longitudinal strain. Traditionally, it wasn't, or historically, it wasn't part of the reports that you see. Like, you may see it sporadically, but not regularly. So that one, it should preferably be reported regularly. Ejection fraction is always reported, which is great. But in addition to that, septal E prime, average E/E prime, tricuspid maximum tricuspid regurg velocity, and LA, left atrial volume index. Sometimes they use other ways to report the left atrial volume, but this is the one that's recommended by our consortium. And I have to say that our consortium recommendations are largely congruent or consistent with the recommendations from the American Society of Echocardiography and the European Society as well, as they outline relatively similar criteria in their 2015 2016 guidelines for systolic and diastolic dysfunction, respectively. So, it's sometimes, the cardiologist our cardiology colleagues may look for their, our own guidelines and kind of formulating or putting the necessary variables in their echoes. So my point is that those variables exist in their own guidelines too, not only in the hepatology document, but it's important to be consistent in reporting them so we can manage and monitor these patients accordingly. And one would wonder, like, what are we going to do with monitoring them post-transplant or monitoring them, post-TIPS? Like, there's no treatment for cirrhotic cardiomyopathy. While this is true, at the same time, we know very well that, there are anti-remodeling agents that are available. So if, for example, if we see the ejection fraction is, dropping to 40 or 30% without clinical presentation, there are medications that can help with that, from beta blockers to ACE inhibitors, etc. So, and I know that limitation in ACE inhibitors in patients with ascites, for example, but I'm just saying, like, there are multiple medications that can help these patients if we catch, for example, worsening systolic dysfunction in the absence of clinical picture. So basically, we catch it in the subclinical phase so we can intervene on it. Regarding the beta blockers interaction with cirrhotic cardiomyopathy, with cardiac function, as I said, these are two studies, and I appreciate the authors of the second study, it was a French group experience, and I appreciate the recommendation about considering echo before, or close cardiac evaluation before beta blockers. But I think we need more data to make that like kind of standard clinical practice, especially like more data utilizing the standard measurements for systolic and diastolic function. And I must say that from cardiology standpoint, all the data support the opposite, that beta blockers are in the best interest of the systolic function, in the best interest of the survival of patients with cardiomyopathy, for pretty much every cardiomyopathy, except for restrictive cardiomyopathy to some extent. So from cardiology school of thought standpoint, beta blockers are beneficial for survival, beneficial for cardiac function. So our observations, or the observations that were reported by our colleagues in cirrhosis, they may speak of the kind of unique nature of our patient population, but at the same time, they need validation to prove that these patients have a phenomenon or have a reaction to beta blockers that is different than what has been established by multiple randomized controlled trials in cardiology.
Perfect. Thank you, Dr. Easy. Doctor Juan Pablo Arab tenía una pregunta para usted.
Sí, muchas gracias, doctor Easy, por la excelente presentación. Mi pregunta es, en relación, usted habló un poco de que post-trasplante esto podía no ser reversible. Ahora el estudio que mostró del año 2020, muy pocos de esos pacientes que siguieron post-trasplante efectivamente cumplían los criterios de miocardiopatía cirrótica. Probablemente acá la respuesta no va a estar muy basada en la evidencia, sino más bien en su opinión de experto respecto a cuán reversible, pensando fisiopatológicamente, es la miocardiopatía cirrótica, y si es que bajo ese punto de vista y su visión, algunos de estos pacientes que tienen una miocardiopatía cirrótica más severa, esto podría negar el trasplante o no ser conveniente, pensando en que post-trasplante una de las principales causas de muerte son cardiovasculares. si es que esto no fuera reversible. Me interesaría tener un poco cuál es su visión al respecto.
So, with regard to transplant candidacy, and the fact that, or not the fact that, and the possibility that this may not be a reversible entity, at this time, we don't have enough evidence to say, like, severe diastolic dysfunction or grade 3 diastolic dysfunction that's reflective of cirrhotic cardiomyopathy, should, disqualify patients from transplant. But at the same time, I would say, like, these are patients that we need to closely follow after transplant, with serial echoes. As I said, we recommended 2 years, but I know of some of our cardiology colleagues who would recommend continuing to follow that patient with echoes until the diastolic dysfunction resolves, or if it continues, then we continue to follow them. So we don't have enough evidence to say, like, we shouldn't give them transplant, for diastolic dysfunction alone, but I think we have evidence to suggest that they are at increased risk of post-transplant complications, and therefore surveillance may be of benefit. Great question, thank you.
Yo tengo otra pregunta para Dr. Easy. Es acerca del NT, ProBNP, que sabemos que está asociado a la falla hepática y a la hipertensión portal, propiamente tal, en el fondo se eleva en estos pacientes, pero también refleja la severidad de la injuria cardíaca, ya sea diastólica o sistólica. Entonces, suele pasar en la práctica clínica habitual un paciente con falla hepática, con hipertensión portal, sin historia previa de cardiopatía, que ingresa con una descompensación edemocítica. ¿Cómo usted enfrentaría esto con respecto al ProBNP? ¿Nos sirve en esta situación o no? Esa es la pregunta.
Yeah, so, because the complexity of our patient population, especially, the fact that, for example, like, they have leg edema, from cirrhosis, and they have a lot of signs of volume overload from cirrhosis, it would be hard. The diagnosis of heart failure sometimes could be hard, and therefore, like, we have to look for multiple or kind of like cumulative evidence. So the BMP, in addition to the echo, in addition to, for example, pulmonary congestion, to come up with the diagnosis, because even in the general population, I mean, you need an additional criterion beside BMP. For example, diastolic dysfunction or left ventricular hypertrophy plus consistent clinical picture, such as increased raised JVD or pulmonary congestion. The leg edema exists in the criteria for the general population, but in our patients, it's pretty much everybody with end-stage liver disease has leg edema, so that would be limiting it. But we should look for other factors, or other clinical features such as pulmonary congestion and ongoing echo abnormality to add it to BMP to be reflective cumulatively of heart failure. And sometimes it's challenging, and that highlights kind of the importance of close collaboration with our cardiology colleagues. I have to say that there was a paper that's now in press. I think it's the unproofed version is available ahead of print in hepatology, about correlating BNP with outcomes and how BNP in the first 3 days post-transplant can be associated with later mortality. And there was a small subgroup analysis in relation to the diastolic variables, such as the EE prime and others, that shows some association between the Sorotic Cardiomyopathy variables and BNP, but especially when the level is high, I mean, they used categories in the paper up to 400 or more. But I have to say, this is in general liver transplant recipients. It's not specific for patients who would qualify for cirrhotic cardiomyopathy, in that they have no prior history of CAD, no prior history of arrhythmia, no prior history of CHF. Just that's a correlation between surrogates and these patients. So and it may be applicable to cirrhotic cardiomyopathy patients. So maybe our patients, if we check the BMP of every one of them, they have higher BMP than usual. But as of now, I would follow what's applicable to general population, looking for echocardiographic evidence combined with BMP, combined with the clinical features that are more suggestive of heart failure rather than, common between heart failure and liver failure or liver dysfunction.
Thank you, Dr. Isi. Álvaro.
Sí, doctor Isi, un par de preguntas más. Entiendo que la nueva clasificación propuesta por usted y sus colaboradores, la idea, digamos, es que sea algo más objetivo y no incluye, digamos, lo que se refiere a situaciones de estrés que hacen que se provoque insuficiencia cardíaca, pero en la práctica clínica a nosotros nos toca ver con frecuencia que pacientes que son sometidos a vasoconstrictores, en particular terlipresina, que nosotros utilizamos para tanto manejo de hemorragia digestiva como síndrome hepatorenal, desarrollan insuficiencia cardíaca. Muchas veces también esta terlipresina está acompañada de aporte de albúmina si el paciente tiene un síndrome hepatorenal. ¿Qué opinión tiene respecto de eso? ¿Cree que la gran mayoría de estos pacientes que hacen estos cuadros de insuficiencia cardíaca tienen de base una miocardiopatía del cirrótico y es un área que tenemos que explorar? ¿O probablemente hay otras razones que explican esto?
I'm sorry, Dr. Orzo's voice was louder than the interpreter voice to some extent. I think it has to do with Zoom.
If you want, I can make the question in English if it's okay.
Well, yeah, that would be greatly appreciated.
Okay, sorry, so the thing is that it's regarding vasoconstrictors in specific terlipressin. We usually see in our clinical practice patients that are given terlipressin for bleeding or for hepatorenal syndrome, and then they develop heart failure after terlipressin infusion. Some of these patients are also given albumin because they have hepatorenal syndrome, and they develop heart failure. So do you think that these patients in baseline, most of them have this cardiomyopathy, or probably are other the reasons that make this happen? So do you think if we check these patients, most of them are going to have the new criteria of cirrhotic cardiomyopathy?
That's an excellent question. In fact, I was talking to my colleagues in our institution because we were part of the terlipressin trial that was published just recently in the New England Journal, and we were wondering if in the next step or in the next trial about terlipressin should we assess baseline cardiac function echocardiographically? Because if you look at both trials, the albumin trial and the terlipressin trial, both trials raised concern about the respiratory compromise in these patients. And there are multiple factors that are happening in these patients. These are very complex patients. Most of our patients have multi-system organ dysfunction, multi-organ failure. But one would wonder, is the common factor for these respiratory compromises or pulmonary edema, is it cirrhotic cardiomyopathy, or is it part of the problem? So I think in future studies that address this question, in order for us to get evidence to guide our clinical practice, we really need baseline echo in all of these albumin and terlipressin patients. In fact, our center is now discussing with other centers in the US the next terlipressin study, and we're proposing that the cirrhotic cardiomyopathy criteria or the assessment for these criteria be included at the baseline, at the inclusion or at the baseline visit or assessment for the study, because we really need to know, like, do we need to treat these patients differently when it comes to albumin and terlipressin? Is it just close observation? Is it different dosing? What do we need to do with them? Because there's this cardiologic entity, and there's this observation of respiratory compromise by these two excellent studies. So we really need to see, is there a link or there's not a link, because that can guide our clinical practice, I believe.
Thank you very much, Dr. Isi. Muchas gracias, Dr. Isi.
Ya estamos en la hora, así que vamos a ir cerrando. Una vez más agradecer la excelente presentación del doctor Manjalisi, fue yo creo que muy clarificadora para nosotros. Es un tema muy frecuente, pero que como hepatólogo, como gastroenterólogo, yo creo que nos fijamos menos de lo que deberíamos, así que probablemente todos vamos a hacer algo distinto el día de mañana con nuestros pacientes, y eso yo creo que es marcador de una excelente presentación. Muchas gracias a los moderadores, la doctora Riga, el doctor Ursúa, que fueron capaces de manejar este tema tan complejo y hacer excelentes preguntas, y a toda la audiencia por habernos acompañado hoy día. Una vez más, gracias a Eurofarma por el auspicio, a la Asociación Chilena de Patología y a la Sociedad Chilena de Gastroenterología por todo el soporte. Así que muchas gracias y nos vemos en la próxima reunión. Que estén todos muy bien. Buenas noches.
Thank you very much.
Buenas noches.
I greatly appreciate you guys having me here. It's a pleasure, it's an honor, and muchas gracias.
Thank you, Dr. Isi.
Thank you, Dr.
Thank
Isi.
you.
Good night.
The pleasure is
Buenas
ours.
noches.
Good night. Thank you.
Thanks.
Bye.
Bye-bye.